The long ones, you think about them, they're going to bear the weight. So we're going to think of a long bone. Somebody give me an example.
Femur.
Femur, there you go. And we also have short bones. Can you think of any of those? Glenoids. Exactly. But they're not going to bear a weight. They're not designed to bear a lot of weight. Then the other thing besides the shape of the bones is our structure. And the thing you need to make sure you know is the eversion system. So it contains, inside the bone contains blood, oxygen, and nutrients in the system. Okay? Our concepts are mobility, which is a basic human need again, and comfort. A lot of people come in for surgeries related to the musculoskeletal system because they're in pain. And the interrelated concept is the sensory perception. Okay, as far as our review, we've got our bones, we've got our joints, and the different muscles. Mobility can be impaired by disease, surgery, trauma. That's what we just did, right? Spinal cord injuries, could be a disease, MS, Parkinson's, all the things that we just had can decrease our mobility, almost all of them. If the nerves are damaged, sensory perception and comfort are affected. You don't want to have them in a chance to get burned, anything like that. Okay. All right, as we look at, we talked a little bit about bones. I want you to know some terms, at least the osteoblast are the bone-forming cells, and that's with a B. So you're going to think of osteoblast, the bone-forming cells, think of good bone, and that is kept in place by estrogen. Then another besides osteoblast is osteoclast with a C. I think it's cancer, but it's a bone-destroying cell. So we have the bone forming, the blast, and then C for clast is the bone-destroying. Okay. So hematopoiesis, you will hear that term. Hematopoiesis, that's the production of the blood cells in the red marrow. And then the fat cells are in the yellow marrow. Anybody in the OR yet? Have you seen actual fat in the OR? What color is it?
Yellow.
Yellow? It's
Looks
amazing.
like corn.
I'm sorry?
It looks like corn.
Looks like corn.
It's squishy.
Squishy, kind of gross. Yeah, I'm sorry. Or even in frogs in biology, but yes, it's always yellow. All right. If we're talking about bones, that's very vascular, and there's very few nerves. There's nerves in the bones. Now the joints, those are the spaces between two or more bones. Okay, and so for those, what we have in those is we have the synovial joints, and that's where it's a membrane filled with fluid, to lubricate. And if somebody has arthritis, they get older, those joints become inflamed, and that's the little bursa, and it's called bursitis, small pockets of fluid. Okay, as far as different kinds of joints, we have three types. We have an immovable joint, we have a slightly movable joint, and then we have the diarthrodial, which moves great. Okay, so that would be like your elbow, your knee, so they can, right, we can go up and down, we can go side to side, we can almost do a circle with it, all right? Okay, the muscular system. Smooth muscle, we have that where? Where's that? Anybody know where our smooth muscle is? It's in our organ, or our organs and our blood vessels. Okay, so that's going to go ahead and track. Cardiac is the striated. And that's for the central nervous system, the cardiac is. And then our skeletal muscular system, I want you to think of that as your framework for the body. It helps in movement, it protects our vital organs. So what are our ribs protecting? lungs. What about our cranium? There you go. And then, like I said earlier, our skeletal framework, it manufactures blood cells in the red bone marrow. It also bone stores calcium for us. It stores minerals, calcium and phosphate. Okay, this is the sad part of life here. Because bones form, they resorb, they destruct, they can do all these things until age 35. After age 35, what does it do? We can't go ahead and reabsorb, and it's not going to function like it did when you were younger. 99% of calcium in the body is in the bones, and 90% of the phosphorus is in the bones. Another term you might need is osteomalacia, and that's the softening of the bone. Osteopenia, so things that are associated with aging. Severe osteopenia is osteoporosis. I think most of you probably have heard of that, right? And that means a decreased bone density or bone loss. And this is especially in white females. Another change with aging is kyphosis, or a humpback. I've already started to develop mine, unfortunately. Curve of the thoracic spine. And you can see my mom, because of her, she's another 3 inches shorter than me. Kyphosis, humpback. Osteoarthritis. Okay. That one's in the hip, knees, cervical, lumbar spine. Most common areas are those, hip, knee, and spine. It also occurs in the shoulders, upper extremities, hands and feet. Does anybody in here not know somebody with arthritis? Does arthritis have an age limit? Exactly. I was devastated. I was 31, just had my last child, and they said, oh, no, you've already got arthritis. And I went, what? I'm only 31. They're like, yeah. Does not have an age to it. Okay, so everything is less elastic and it's compressing the joints. That's where arthritis comes in. Muscle tissue atrophies, so that happens with age as well. So the muscle tissue, if we're not going to use it, we're going to lose it. You've heard that before. So if we increase their exercise, and they're exercising on a regular basis, they'll have a slower progression of muscle atrophy. And it'll also keep their strength up. You'll see people at older age with less coordination, because we've lost that, loss of muscle strength, gait changes, and increased risk for falls. Okay. All right, that top one for health promotion, avoidance of risky lifestyle behaviors. I'm glad you guys all got the 18-year-old for the, and the last one. That was good for the risky lifestyle behaviors. So what kind of things do we have to think about? Making good decisions. And that goes all through your life. So you're young, you don't want to make stupid ones. I'm going to use my mom as an example. She's 89. She has to mind the rules too. So now we don't let her have a step stool. She can't have any throw rugs. We've eliminated all those kind of things from the house. So because that would be very risky for her. Okay, vitamin D. Why is vitamin D important? Absorbs calcium. Very good. All right. We talked about weight-bearing activities. Walking is the number one. How much exercise do we want? 30 minutes. Minimum of 30 minutes during 5 times a week, 3 to 5. Things you need to do with health promotion. Tobacco smoking has negative effects on the musculoskeletal system. Nicotine's a cause, so we know it doesn't help the cardiovascular, doesn't help the musculoskeletal, doesn't help the nervous system. So nicotine's just bad news all around. What happens if somebody has excessive alcoholism intake? What does that decrease for them? They're too busy drinking. They don't take in their vitamins and nutrients that they need for healthy bone growth. All right. How do we assess our patients for issues with their musculoskeletal?
Range of motion?
I'm sorry?
Range of motion?
Range of motion. Yes, we will definitely will be checking range of motion. That'll be on your next slide, so good. When we're talking to them about it, what kind of things do we want to ask? Did you play sports when you were younger? I mean, does anybody in here have any kind of sports injury that they had once upon a time? Anytime? Yes. So they say, okay, that's going to bother you now. We'll get you back in the race. We'll get you back in the game. But did they tell you how it's going to affect you later? You're young. You don't want to know that part, right? So that can be a big game changer. I had a back injury when I was in volleyball. Didn't think anything about it. But when I was in my 20s and having my first babies, it became a problem. And then we could relate it back to what it was. So a motor vehicle accident or sports injuries are big. Are they already on a pain management plan? Are they already using opiates or cannabis? You know, are they already doing that? Because that's going to change their treatment as well. I'm just going to tell you with the cannabis. So it's not legal in Missouri yet, right? What's that? Okay. The one thing I have seen as a nurse, and this is over many years because it's been around for many years, people that typically use marijuana on a regular basis, they come in the hospital and now they've had to have emergency surgery. They may have to get the gallbladder out, or they've had a car accident or something like that. They cannot achieve pain control like somebody that doesn't use. Okay? And I think it's because they're accustomed to that euphoric feeling, and they can't reach that because we can't give them marijuana in the hospital. But so pain meds don't typically work as well for them. So if you have the chance to discourage, that's where I would definitely go. Another thing you could ask on their assessment, do they have diabetes? What's that going to do to the healing process?
Slow it down.
Slow it all down. What about, what kind of work do they do? How's that going to matter to the musculoskeletal system?
Repetition, like repetitive motions.
Repetitive motions would lead to some carpal tunnel if they were a computer person. What if they were a roofer? They're up there hammering away, right? Where's our repetitive motion? That shoulder. You know, so that's going to make a big difference. What about allergies? How would that make a difference? What if they have a dairy allergy? It's going to affect their calcium, yeah? So they may have to do something different. What if they are on a low protein diet? Now that's going to cause problems as well because we won't be able to utilize that calcium. If they're anorexic, that would be problems as well. And that's just going to, if they don't have decent vitamin C and D, it's going to decrease their healing. What about obesity? What's that do to the musculoskeletal system?
Increases strain.
Yep, extra strain. It's hard on your joints. Decreases their mobility. And if their mobility's less, that's less exercise, less keeping the strength up. Nutrition, we talked about family history, a genetic risk. Gout is a big one. Okay, that and osteoporosis are both genetics that affect those. And gout can do males and females. You have in your modules, there's a thing on the purine diet, because that's what we'd have to go purine diet for somebody with gout. Things that we're going to see with these patients for their onset. How long have you had your pain? Where's your weakness? What's it stop you from doing? Is it just muscle pain? Is it nerve pain? Do they have neuropathy? That type of thing. All right, when we look at the patient, and that's where your range of motion is going to come in on this one. So general inspection, we would palpate, and then we can do range of motion. All right. Posture, you're going to be looking at. That's your total alignment and body build. And people can associate, not just, they can associate your confidence level with your posture too. Keep that in mind. So good posture is always important. All right, we want to make sure, what's another word for a curvature of the spine? Scoliosis, so that's the one with an S. What about lordosis? What's that one? That's if they got a big belly. Have you ever seen somebody with a big, huge belly and then they've got that curve in on the lumbar spine? Have you seen that? Lordosis, Lordosis. Mobility and functional assessment. Do they need any devices? Are they able to do their ADLs without question? And when we're looking at them for their inspection, I also want to say that it's very important that you compare limbs at the same time. So, but you're going to go to the affected one first. Oh, I've got an infection in my arm or my hand. Look at that one first, and then look at the other one. And then you're going to compare size. You may have to measure things like that. Also, you're going to be looking, when you think of the neurovascular, you're going to be thinking of the skin color, elasticity, and any kind of lesions. But why are we looking at the color for neurovascular? I want to make sure there's good blood flow. We'll be checking our pulses. Color can tell you a ton. I mean, it was sad. I was 1 o'clock this morning. I was still trying to get to sleep and peeked at Facebook, and I saw a nurse that I used to work with, and it was her 25th wedding anniversary. And her husband's, I knew he had bad health, but he's in shorts. Nice guy, great guy. But from knees down, I immediately noticed the discoloration. Okay, so it's something you're going to pick up on in a big way. I mean, what if people didn't have masks on and you're at the grocery store and you see their lips are blue? Are you kind of worried about them? They're stopped, they're hovering over their cart? Yeah. You'll start noticing things all over. Remember, my daughter asked me questions, well, how'd you know that about that person? I said, I saw their zipper, saw their scar. They've had open heart surgery that, you got to watch, be careful. She's like, how do you know these things, Mom? But as a nurse, you're going to start noticing more and more and more things about people. Okay, muscular, how do we measure? They have listed in your book a goniometer. I have never in my life used a goniometer, okay? Physical therapists use them all the time. I guess nurses, we can. But so like the flexion of a knee, after a knee surgery, and they're trying to get how much can we get function back in that knee. So that gives the exact measurement. We can do, like you said, range of motion, active and passive. All right. So here we have, why don't we go ahead and just do some of these. I know you guys know how to flex, but this will help you remember. Flex and extend. Okay, we're going to bring them in. Adduction, we're adding it back to the body. AD, adduction, abduction, going out. Okay. Pronation. How do you know the difference between pronation and supine? How do you remember that? Supine is on the spine. You're laying like this. Okay, and prone, if you were down, facing down, prone on the bone. You think you'll remember that one. Okay. Inversion, so feet are in. Eversion, outward. So in is always very helpful. That would be good. And right now we just even need to take time to rotate our head. Is anybody's cracking while we're doing this besides mine? My lack of calcium's going to get me. And I'm not kidding. Okay, circumduction. Okay, so all the way around. Can we bring those arms and those shoulders? All right, this elevation depression, some of you know that I like to play the piano, and when I get really into it, and I've got a tough passage in this left hand, and I would be like this, not even realizing it. So my instructor would make me take a purse and put it on this shoulder and play the piano with that purse there to make sure that my tenseness, because you'll be watching, you will see the difference in your patients, or you'll see. I know that my dad had trouble with his lower back, and the doctor said, but you always have your billfold on the right side. And so with his gait, so he made him change his billfold to his left back pocket. Something simple like that can change their gait, okay? All right, muscular, didn't it go? That'll work. Okay, in our assessment, besides physically looking at them, what kind of labs? It says chart 49-2. I want you to put page 979. There's a huge chart on there and it's not labeled. So we're going to check their serum calcium and their phosphorus. Okay, the ALP, alkaline phosphorase, is present in the blood. If it's elevated, it could be liver damage, could be bone damage, or bone mets, bone metastasis. Not fun stuff. Okay, in your book, I think it's 980, you'll see the CK, which is the creatinine kinase, the LDH, the lactate dehydrogenase, AST, the aspartate aminotransferase, and the ALD, the aldolase. All these are enzymes, and they will tell you if there's issues with the muscles. Okay? And then that affects the bones. All right. To see pictures, so we talked about the different labs we would look at for musculoskeletal. Imaging, so our x-rays taking our pictures. CT, which is a great test, it's quick. What do we need to be worried about if they're doing contrast? Allergies, okay? MRIs, they are still the most accurate testing for joints, soft tissue, for bony tumors. CAT scan is still the first choice because you can do that if they have metal objects, because MRI you can't do if they have metal objects. But the CAT scan is the quickest and the fastest. You may take you weeks to get into an MRI appointment. Okay, so they can still gain a lot from the CT, which is our first choice. The ultrasounds, so those help with our bone density, and we can check the joints, the cartilage, and the synovial swelling. Nuclear scans. Has anybody seen a nuclear scan or had a nuclear scan? Okay, there are a lot of times they will refer to them as a bone scan. And if you look at the picture, it's got their whole skeleton. Okay, most commonly used to rule out cancer. That's one of the big things that we'll be looking for hot spots. So they'll say, there's a PET scan, how did it turn out, your bone scan? Do you have a bunch of hot spots? Because they're looking to see if there's metastasis of the cancer. Things for the nuclear scans, tumors, arthritis, osteomyelitis, vertebral compression. So it can show you if we have a compressing spine, fracture, bone pain, which is a lot of times can be cancer. It can show hairline fractures. As far as cardiac, you heard of a thallium stress test maybe? Okay, that's a test where they're going to inject the thallium and it's going to change and increase our heart rate, that type of thing. But with the bone scans, typically we do gallium, G-A-L-L-I-U-M. Now the thing as a nurse you have to know is they're going to inject the patient with gallium, okay, in their IV. But it has to be done 4 to 6 hours before the test. Okay, so the problem with that is that tech is not going to stay there till 11 or 12 o'clock at night. So if the doctor orders this nuclear scan, bone scan, and he orders it at 4 o'clock in the afternoon, we're not gonna get it till when? The next day. And it's imperative that we let them know, because they have to have those orders ahead of time. They won't always have the medication needed, the isotopes, they have to be ordered. So as a nurse, if you know at 7 o'clock at night that you're gonna have the isotope, they're gonna have to have this test, we need to call radiology, make sure they know so they can have the isotopes ordered. And then those isotopes are delivered from outside of the hospital. But they're very expensive, so you're not gonna get them very often. Now, when they take this test, the nuclear scan, they have to be able to lie flat for 30 to 60 minutes. Okay, so that's 4 to 6 hours after the injection. Then they may want to go ahead and check that absorption again later. So they could do it again in 12, 24, 48 hours. They might scan the patient again. What do you think our little confused people are going to want to do if we're trying to give them a bone scan, a clear med scan? Are they going to lie still for you for 30 to 60 minutes? No. So we can give them some mild sedation. Okay? Questions on these? How we're going to diagnose things. Arthroscopy. Has anybody in here had an arthroscopy before? No. Okay, sounds like a big deal, right? It is a big deal. Anybody doing something to your body, you think of yourself as a patient, it's always a big deal to you, whatever it is, especially if it's anything new, it's scary. Okay, this is a diagnostic test or can be considered a surgical procedure. And what they're looking for, it's a direct visualization. So they're going in and then they've got the camera so they can see what's happening on the inside. And what we're looking at is we're looking at the ligaments, the meniscus, and the articular surfaces of the joint. So you may not know that you have arthritis, but this knee's driving you crazy and it's hurting. But once you go, and they go in there, and he'll say, I cleaned it up some, because a lot of times they'll go in and then they'll scrape parts off if they can and help. They can do a biopsy on the inside, the synovial biopsy. And if they have to, then they can do surgery to repair. So we're getting our patient ready for an arthroscopy. Most of all, it's outpatient, because it's not that invasive, right? And this will be a lot of athletes or anybody over the age of 50. Things we need to think of. What kind of anesthesia do you think they'll get for this? They can have a light general, so very, very little amount of a general, or they can have a local, or they can have an epidural anesthesia. We talked about earlier, what would we really need to assess on this patient if they've had surgery? What do we want to check past that site, right? Down. Distally, we need to check what? We're going to check pulses. What are we going to, so we're going to check the neurovascular, so we're going to see if they have sensation afterwards. What kind of color do we want? A nice pink color, that it's warm, the pulses are good. They've got pain reception so they can feel a point, and we can check their capillary refill. What do we give these patients for pain? This is an outpatient, this is it's a minor type of surgery, unless there's problems in the knee itself. But typically they would just get Tylenol. We elevate for the first 24 hours. 12 to 24 hours, and definitely keep ice on it for 24 hours. Okay. Complications would be swelling, increased joint pain, so it shouldn't increase their pain. Thrombophlebitis, what's that? Thrombophlebitis. Okay, correct. Or infection. All right, let's do 3 questions and then I'll turn you over. So based on what we did today, nurse caring for 4 female patients, which patient is identified as being at greatest risk for low bone density? 22-year-old Asian American, 39-year-old Caucasian American, 44-year-old Native American, 50-year-old African American. And I have the answers today. Look at this. B. Caucasian woman. Yes. We said white females, high risk. Okay? They have the least amount of bone density of any group. All right. Question number 2. After providing education, which patient statement does the nurse identify that reflects an older patient's understanding of musculoskeletal health interventions? I should use my cane. No, not quite. I should drink 8 ounces of orange juice daily. That's not a bad thing, just not the answer. I should try to exercise at least 5 times a week. Yes. 30 minutes 5 times a week. I like D. I should ignore my pain and just get used to moving slower. All right. Question number 3. Patient is scheduled for an electromyography to evaluate diffuse or localized muscle weakness. What question will the nurse ask the patient before the test? When did you last eat or drink? Have you completed your exercise for the day? What herbs or over-the-counter meds do you take? Or did you take your Flexeril this morning? Which ones do we want it to be? Herbs, yes. If a patient has taken herbal or over-the-counter medications that interfere with clotting, the test may need to be delayed or rescheduled. And it's contraindicated for those undergoing anticoagulant therapy. What's one of our anticoagulants that you guys would ask about? What's one of those meds? Coumadin, heparin. Warfarin is another name for Coumadin. Okay. All right. You guys look worn out. Questions on this portion? I think you made it through nerve. So now we're headed on, but I think you'll find musculoskeletal a little bit easier. But we can't do musculoskeletal without circulatory. Without nerves, okay? We can't take care of that without fluid and electrolytes. You're finding that it's in everything. Everything we're doing is constantly building. All right.
Yeah, I'm sorry to have misled you about having class after testing. There are some times if testing hasn't gone well where we try and shorten things. But anticipate that as Sally rolls, that you'll have, after test, you'll start the next unit. So my apology for that.
All right. Stand up, stretch, move about. Restart this, or do you just change a
There
user?
should be a change of user.
I didn't see